I would say possibly the most underdiagnosed knee condition is probably lateral knee instability. For instance, in our office, we'll see plenty of patients who had a knee replacement, and since they know something's not right, but they'll go to the orthopedic surgeon, and the orthopedic surgeon, rightfully so, would say, no, the knee replacement is fine. But people don't realize the joint can still be loose, and the problem is if you get lateral on the outside looseness of the joint, it, of course, could affect the peroneal nerve. And that's actually why we're making this video. So I've even had people with horrible foot pain on the lateral side, saw all kinds of podiatrists, and it turned out it was a peroneal nerve issue. Hauser's law, again, I mention that a lot, but people need to know this. So if you have a symptom or a disease and nobody can figure out the cause, follow the neurology. Like if you have a heart arrhythmia, follow the neurology of the nerves that go to the heart, like the vagus nerve, and it's going to probably lead you to some kind of joint instability as the cause. So this is just some nerve syndromes that have a joint instability component as the cause.
Yeah, this is a pretty in-depth table here. So peroneal neuralgia, pain that might even start at the lateral knee and kind of go down and kind of spread maybe more towards the top of the foot. Most common unstable joint that would affect that would be that lateral knee. And then, of course, the lateral collateral ligaments, if they're loose, they're stretched out, that's what's going to cause that instability. And nerves, they lay right next to the bone, because the bone technically is supposed to kind of protect the nerve. But if the bone is moving too much, that nerve lays right there. So it doesn't take much for it to get irritated.
So you said peroneal nerve can cause, kind of like referral pain on the lateral calf and lateral foot. Then what muscles does the peroneal nerve innervate, right? Because you got to realize, like, if you have a nerve that's not working so good, some of the nerve impulses may not go to the muscles, then what would that cause?
So people with drop foot, if you think about your foot when you're walking, like everything should just kind of move fluidly, but some people, like their foot just kind of flops, like it just drops. They can't actually bring their foot back up during a normal walk. That actually can be a peroneal nerve issue from the lateral knee.
Yeah, or somebody doesn't have classic foot drop, but they know that the foot feels weak.
Yes,
so the foot feels weak. What are some of the signs or symptoms that somebody could look for when you're at home to just maybe think about if you have lateral knee instability?
Sure. So first of all, do you feel like your knee's ever going to give out, or if you do have like a lateral knee pain with this kind of referral, but if let's say you're just sitting at home and you move your knee and you get like a lot of clicking or crunching or popping, you can feel that on the lateral knee if you just put your hand on there. Or even if we think about knee anatomy, your fibular bone, which is actually like the long skinny one on the outside of your calf, that attaches at your knee right here. So here's like what people think of with typical knee joint. The fibular head comes and attaches here. Some people in more severe cases will actually feel that bone move. That again is another clue for lateral knee instability. If you just even get a nummy feeling, let's say your muscle activation is fine, you can walk fine, there's no weakness, but it's just like a nummy sensation, or it just doesn't feel the same as the other side, that could even just be like a superficial peroneal nerve issue.
I mean, I'll just do it. I'm obviously in a chair, but I mean, basically if somebody just goes like this, if they just went like this, they'll feel all kinds of clicking, popping, grinding on the lateral side, and that's kind of what we do when somebody comes on physical exam. Now, we have the benefit of showing the instability with an ultrasound, so we'll show that later. I made this for the neck, but it really applies to any kind of joint instability. So you start out with a normal, healthy nerve, and once you get to neuropathy, it means there's actually nerve injury. Now, there's people who've had EMGs or nerve conduction studies, because basically that's the main test in modern medicine that can tell you whether you have a nerve injury or not. The test is going to be normal if you have intermittent compression and stretch. So that's where the doctor suspects that you have a peroneal neuralgia or injury, but then the EMG test, when they go into the peroneal muscles, they're normal. The nerve supply is normal. It's because joint instability can intermittently stretch or compress it, which will irritate the nerve or can block nerve impulses, and if it blocks nerve impulses to the muscles, that's where you get muscle weakness. So
Yeah.
intermittent muscle weakness would be a sign of peroneal neuralgia.
In that case, if somebody is like, yeah, I have this intermittent knee pain and I have this kind of numbness, it comes and goes, just bothers me every once in a while, still should probably take care of it, because you don't want to end up that person that, oh, I've been dealing with this for 15 years and now I'm at the point of no return.
It's a lot less visits. Like if,
Totally.
like if you get all the way to here and you're trying to,
Yeah.
like that might be, with us, it might be 6-8 visits, but if you come like here, it may just be 2 or 3 visits. So.
And here, like if the nerve is just getting stretched a little bit and it's intermittent, we don't always have to treat the nerve in those cases. You know, if we know there's a really unstable joint that's just kind of giving intermittent symptoms to the nerve, maybe, you know, we just stabilize the joint on its own, and that's all we have to do.
Then we talked about here. So from a prolotherapy standpoint, so if you have instability on the lateral side, we'll treat the lateral ligaments. The main one being the lateral collateral ligament, but there's ligaments back here too. And then we have to do it under ultrasound, right? Because you have to see where the nerve is.
Yep.
What are some ultrasound indications that there's a peroneal nerve problem? Because you can actually see the nerve.
Sometimes it's handy to even look at both sides. Like if somebody has a symptomatic right knee, but their left knee is completely healthy, you can look at the nerve and you can measure it, and you can kind of compare, oh, if that right one is more swollen compared to the left. If it's not as hyperechoic, which is an ultrasound term, it's not as bright. You know, if it's losing its brightness, it's swollen, those are symptoms of nerve injury. Okay. Or I should say signs of nerve injury on ultrasound.
And then technically, as you treat the joint instability and or treat the nerve, the swelling of the nerve, it can go down.
Yeah.
Like you can actually measure it and see it.
Yep.
And it, in my experience, it does correlate with the improvement that the person's saying. So though we're talking about peroneal nerve issues, all the principles apply to carpal tunnel.
Oh, totally.
You know, cubital tunnel, tarsal tunnel, like any sort of nerve issue in the body, a peripheral nerve, it's the same principles. It goes from normal nerve to neuralgia, where you start getting stretch and compression. Then if you don't do anything about it, and the joint instability, which is a progressive disorder, leads to, like you said, neuritis and then neuropathy. So neuropathy is the end stage where you actually have damage to the nerve. So that's going to take a lot longer to recover then. And then, of course, if beside just the nerve getting injured, the joint's going to get injured, because you have a simple ligament injury which progresses to...
So like here, completely healthy, normal knee, ligaments are white, it's completely healthy ligaments. You start to get a ligament injury, you tear it, you sprain it, you know, somehow injure it. Over time, it's going to increase the force on your joint, where you'll actually start to get more ligament injuries and wear down your cartilage, your meniscus, your bone, all important structures in your knee. So an objective way of showing joint instability is simply to just stress the joint under ultrasound. This is the lateral knee. So these bright white lines, those are the bones in the knee. There's the space. And then here I am holding it. And if I just put some stress, we call it like a Varus stress test, and I can actually watch this gap, like those bones spread out more than they should, that's going to be indicative of lateral knee instability. And of course, the beauty of ultrasound is you always can compare to the other side. You know, if somebody has an asymptomatic left side, that joint is stable, you can see what that looks like versus what the injured side looks like and compare.
What about the person who says, you know, I saw an orthopedic surgeon or a physical therapist, I don't understand like why they didn't diagnose this. So like, you know, because people might get MRIs and and then the MRI doesn't show that there's ligament damage. And then they come here and you say this opens up, say 3 millimeters. So it with your stressor maneuver, it opened up 3 millimeters on the right side. The left side, you did exactly the same thing and it didn't open up. So obviously there's a discrepancy on your symptomatic side. So how would you answer them, like the other tests the person did?
Well, what we always have to remember about MRIs is MRIs are done when you're laying flat perfectly still, right? So are they great for looking at things like meniscal tears and so forth, ACL tears? Absolutely. But you don't stress the joint in an MRI like you can do on ultrasound. When you have an unstable joint, first of all, it's not going to show up typically if you're just laying flat. You have to move the joint to actually know if it's unstable. I don't know if the joint is unstable until I stress it.
Yeah, that's true. An MRI can't tell you whether a ligament's strong or not.
No.
If there's a lot of damage to it, it can show it, but if there's microscopic damage, so you could have damage that if you saw the ligament, you can't see it, but the ligament's damaged because it's not holding the bones together. So that's where you gotta move the bones. So if the bones move excessively, it means whatever's connecting the bones, it's not doing its job.
Exactly.
So when would you determine that a person just needs peroneal nerve injection? And then you said you would use platelet-rich plasma. And then when would you decide to do prolotherapy? And then how many visits is it normally?
Those are all good questions. So if somebody comes in and they have signs of, peroneal nerve injury, first, is the joint unstable? Let's say they come in and they have this nerve injury, but they have a completely stable joint. I mean, there's no reason to do prolotherapy if your joint's completely stable, but we still want to get rid of, symptoms that are related to the nerve. So there are times where we'll just do peroneal nerve injections. Most of the time, we use PRP because it has a lot of healing growth factors for nerves. And we know that nerves respond well to it. So we'll use that.
Yeah.
Number of visits always correlates with how bad the symptoms are. More intermittent symptoms are not going to need as many treatments as things that are more chronic and constant. For an intermittent one, maybe we do it a couple of times, 2-3 times, and they're golden. For things that are more chronic, we might have to do it more in the 5 to 6 range.
Nerves actually like vibration. So I think the more damaged a nerve is, the more just vibrating the area. I think that helps too.
And people, with patients, a big part is education. If we're going to go through all this work to stabilize the knee and regenerate the nerve, we don't want people to go home and then stretch it all the time. Even as simple as like people that sit kind of like cross-legged all the time, that stretch, just little simple things that people might have to just kind of alter or modify in their daily life. Those are going to be good things too to help with the goal of stabilization and healing.
And then if a nerve problem has progressed to neuropathy. So when you have neuropathy, that means there's actually nerve damage. So you actually have to give the nerve a reason to regenerate. So like you said, you inject some stem cells, bone marrow, or PRP around the area. Then the skin has 5 sensations. So if you have a neuropathy, like you have numbness and you have some muscle atrophy in your foot, say, then the skin has 5 sensations. Hot, something hot, cold, soft touch like cotton, sharp touch like a needle, and then vibration. So those are the 5 sensations of the skin. So if you have numbness in an area or severe pain in an area, it's probably going to help you if you try to stimulate that area with those 5 sensations. So it could be you vibrate the area where it's painful or numb, and then you could put your foot in hot water, cold water, you can get in a pool. You could, in the past, I've had people have a bowl with cotton in it, and then that's for soft touch and sharp touch. I'd have had them, same kind of bowl, but put popcorn kernels in it. Because, if you never stimulate the skin, like you have burning pain in the skin from a neuropathy, then why should the nerve try to repair itself? So those are just little pointers.